lesions are there, huge tumor around it, might be almost look like either the neuropathic joints or like that, or osteochondromatosis. Now, go through the metastatic lesions. Here is one osteolytic lesions over there. Punched out areas, so differential diagnosis will be either metastatic lesions, and of course you will have to see is adult bone, so multiple myeloma. You will have to think of it. In the ribs, also osteolytic lesions very often you see. In the spine, you see everywhere if you trace the vertebra, you will see this pedicle shadow, this wall shadow, and the spinous process. It looks like an owl. If the owl closes the eye, that is very suspicious. Owl closing the eyes. You find one here, but this is disturbing, and here you don't find that eye. So that is very suspicious. Osteoblastic metastasis. And in some metastasis you will see both, I have shown you only osteolytic. There are osteoblastic lesions. And there might be some osteoblastic and osteolytic. Both metastases are there. Here is some example of osteoblastic. Here are, you see, the pelvis, spine, here. But thing is that you see that joint space is maintained well. Only thing is that you don't find the owl's eye. Here is a mixed type, mixed pattern, osteoblastic and osteolytic lesions. You will have to, osteoblastic purely, you will have to differentiate with another lesion. What is that? Pagets, no, but Pagets is sometimes osteolytic and mixed type. But osteopetrosis, marble bone disease. Let us see about some lesions like infective lesions, the osteomyelitis. We have talked much. Dr. Gupta has also shown you many pictures about it. And only one question I like to ask you, that why the sequestrum is more dense in X-ray? Very pet question by the examiner. Why the sequestrum is more dense in X-ray? Number one, vessels are cut. It is avascular. Secondly, the surrounding areas are black. So you need to see. And third, that is end on view sometimes. Suppose you see and get the X-ray flat. But if you take the X-ray like this, it will be much more dense. Understand me? Probably those who have not, please ask me later on. Another osteoarticular tuberculosis is tubercular arthritis. Tomorrow, I think Professor Tuli will tell you much more about it. This is another. And miscellaneous, some of the X-ray I will show you. This is one X-ray, it's a normal hip, you see. And that is another. What is this? X-ray picture is not good quality. Parthis, of course. Here are some example. And in Parthis, there will be some lecture and case presentation, I think so. And you will learn much more. But thing is that typical X-ray, head at risk. What are the radiological signs of head at risk? This is a common question you will be asked. You know, here if you put a line, it's a lobar succession. And what are the other changes in the head? There are cystic, this is broaden, angle, etc. Everything to mention. These are the common questions. Don't think you will be asked very unusual question. But this common question we ask to the DNB and the MS Orth questions. But at that time, what happens, I do not know, but most of the students failed to answer. This has also been, I told you that quality of the bone should be assessed. Quality of the bone, as you have already seen, thin cortex and there is some wedging. It is osteoporosis with wedging. It is another aspect, you know, everybody will be able to answer. Rickets, nutritional rickets. And the healing, there is some calcifications is going on. Here, so many, this is not a good x-ray. Only a few days ago, I got a patient, 6 months old, only 6 months old child having this problem. Bone is little, there is little bit thickening of the soft tissues, you were crying, and you see the tibia. What are the possibilities? What are the possibilities? One is the definitely osteomyelitis. Anything? Not syphilis, I don't find nowadays. I think you will not find. Any other thing? Osteomyelitis is one. There is, you see, the bone is, there are a lot of periosteal reactions. If I have an X-ray of other bones, I can have it. Yeah, Capes disease. And one more differential diagnosis will come. What is that? In children even garage might be, but other things, some deficiency of something, one vitamin deficiency, scurvy, subperiosteal hemorrhage. Okay, that will mimic the similar picture. And here is almost the last picture. On the right side, these are the normal bones. These are the abnormal bones. Can you tell me the diagnosis? Multiple? Yeah, any other? This is my, I got an answer. Fluorosis, skeletal fluorosis. Here you see osteopetrosis or marble bone disease, you will see the bone outline will be absolutely normal. Outline will be normal. But here you will see some irregular bone formations. Okay. And sacrotuberous, sacroiliac ligaments, there is a lot of calcifications, including vertebrae I cannot show you. But irregular bone formations are characteristic of sclerosis, skeletal fluorosis. That you should know because you know presently there are more than about 25 lakhs are suffering from fluorosis in our country. And about 19 states have been affected. So you should know a little bit about it. Thank you.
Thank you, sir. Thank you so much for your valuable thoughts. Now I would like to welcome Professor Sahu, sir, to come on the podium, please. The topic of his discussion will be soft tissue coverage for compound fractures.
Okay, before I start this discussion, let me tell you the students are bored or they are really hectic to know. Because it is already 5 months, past 5. You are all postgraduate students, na? Be friendly to us, don't worry. So because at the last, fag end of the lecture, I want to cover up everything. Because to cover the bony areas or defects by soft tissues. Are you interested to hear? Yes. Okay, then we will proceed. First of all, you should know what is a compound fracture. I think everybody knows. Okay? But what do you mean by potentially compound? Anybody can tell? What do you mean by potentially compound? You should react with me, otherwise what is the use of, because we will be giving an English lecture, then you will be going away. Yes. Why it is called potentially compound? Because possibly, means in the maxillofacial region, they may be communicating to the sinuses. And the sinus is always exposed to exterior. So therefore, for all practical purpose, it is taken as potentially compound. Whenever anybody asks what is potential compound, you should have these are the fractures which are potentially compound. Clear? What is the importance of compound fracture? I think you know. There is no necessity of discussing everything. First of all, the infection, isn't it? Because it is contaminated, so in fact the probability, possibility, you are anticipating so many things will come because of this infection. And the more soft tissue injury also in along with this, because the bone is covered with so many soft tissue like muscle, along with it also there are neurovascular structures along with the skin. The more psychological also, the patient is himself also is worried that I have bled so much and all these things, what will happen to my life. So all these things is taken into consideration once it is compound. And mechanically we will take it that the compound fracture are duration specific and also area specific. Supposing it is, I think you know the Gostello classification. If it is less than 1 cm, doesn't matter, we can stitch and go away. But if it is 4 centimeter, then the probability of infection and the contracture or complications are more. Similarly, duration specific, if you have attended the case within 6 hours or within 12 hours, it is in the golden period, you can do something. When it is beyond this, you are also in a trouble. So therefore, all compound fractures have got duration specific and area specific. I think area specific, you know the Gostello classification, out of which the third B is very important, because the bone has shattered and always associated with soft tissue injuries. Subtype third B is very important. I think you know this. Why do you classify this? What is the necessity of classifying this Gostello, any fractures? Because the open fracture classified into 3 major criteria, depending on the mechanism of the injury, soft tissue damage, and degree of the skeletal involvement. Therefore, the mechanism of injury, I think I have got the last lecture on biomechanics, because there are different types of stress. So that means what are the loads, the forces are acting on you, and what are the types of fractures you usually get. Thus, from this, you can anticipate that directly, because this anticipated complication is directly proportional to the type of fracture. So therefore, we are classifying these compound fractures into different grades according to Gostello. There are a few examples, I think you know better than these pictures. Now we come to the management. Traditionally, true surgical emergency. It required operative debridement and fracture stabilization. Wherever you are going to manage any fracture, or whenever you are going to manage this area, you require stabilization, means there should not be any mobility at all. Because it will not only perpetuate the healing of the bone, also it will facilitate the healing of the soft tissue. And the golden period you know better than anybody. What are the debridement? The things you are to discard it, throw it. The things outside which has come in, dead devitalized tissue, skin and muscle. Can I ask few questions? How will you know that the skin is dead? No, you see, these are very practical things in your life. You just by scalpel, just give a very small incision, if it bleeds, then the skin is live. If it does not bleed, it is dead. And remember, whenever there is any deglobed injury, the muscle is there, but the skin, lot of skin has been deglobed, you see it. If there is vascularity, you take the Thayer's graft and put on the muscle, because immediately you can cover it. So deglobed skin, because it is deglobed, just cut it and throw it. No, you take care of that. If at all any vascularity is there when it has reached you. Clear? Then another is muscle. How will you know the muscle is dead? What is the normal color of the muscle? Yes, somebody told? Pink. It is pink. Usually it is pink. When it is dead, how it looks? Yes. Browny or grey. So you know, and also you see the contractility. Clear? Don't keep any dead muscle. Sure. And what is the interpretation of the vascularity you see at the tip of the fingers? Who can tell? Supposing the limb is injured and you see the vascularity, how will you know that the, yes, vascularity is intact? Normally what is happening? Normally when you press, it becomes white, and if you leave, instantaneously it becomes pink. Then go, second step. Supposing it does not go instantaneously, but slowly it becomes pink, what is that? No, you must answer because you are doing PG and will come one day here. You should answer. If it is not coming instantaneously becoming pink, slowly coming, means there is obstruction to the vein. And if artery is obstructed, nothing will come. Clear? It will remain as white. These things are very practical things whenever you are attending any emergency. Clear? Bone without periosteum, nerve without nerve sheath, and muscle without, tendon without tendon sheath. Things should be preserved. Bone fragments having the periosteum or a substantial part of the bone which is taking part in the joint as well as taking part in the length and width of the bone should be kept, because often the dead bone, what is going to happen also, makes a scaffold on which the periosteum can grow as you are giving bone grafting. Because when you are taking bone pieces, they are not alive, but they are becoming a scaffold on which from the sides the periosteum are growing and you are getting union. The vessels, muscle with the viability, viable skin, bone with the periosteum. The things should be covered at any rate. That is the bone. You should not keep it bare. The joint must be covered by any rate. The nerve. Exposed vessels means neurovascular bundle. One may take the latitudinous of the muscle because muscle is so vascular. If it is also remain open, also for means in secondary stage we can go for skin grafting, no problem. The secondary debridement, because you have done debridement first, but you are not sure that you have done quite well debridement of the area. The secondary debridement has got a time factor, that is within 5 days, because beyond which you get collagenation and it is very difficult to take out all debris there. Wound care priority. Why at all you are doing to wound care? What is the necessary? Wound is there, address it and ask them to go. No. Because you can discover and treat injuries critically deep to the structure what you are seeing. Cover the critical deep structure with the skin. By this covering, you prevent infection. Suture only when necessary. Because often the compound fractures if remain open, the obstruction, the secretions also gradually goes out and the wound gradually becomes thin. Now we are using also this negative pressure system so that it perpetuates the formation of granulation tissue better. Maintain function unhindered by contracture, and cosmesis is taken as the 5th point of management. To achieve temporary cover, you require grafting. To close an open wound, to prevent infection, hastens initial healing and prevent exposure of the underlying structures. For definitive cover, to provide permanent skin replacement, which is supplemented with sensitive and durability, or to surface areas of scarring and contracture. What is the definition of graft? A skin graft is a tissue of the epidermis and varying amount of dermis that is detached from its own blood supply and placed in a new area with new blood supply. Whereas a graft, it maintains its blood supply to the origin, means host area. The grafts could be autogenous, homogeneous and xenografts. I think you know it. Homogeneous means this homograft or allograft are same species. Xenografts are other species. The types of graft, it may be split thickness or full thickness. Split thickness contains 100% epidermis and a portion of the dermis. Split thickness grafts are further classified into thin and thick. Whereas full thickness, it contains 100% epidermis and dermis as well. The difference you can know, what are the advantages of split thickness, what are the disadvantages. You see, if it is thin, the best survival heals rapidly, but disadvantage is maximum secondary contracture. That is the most important. In thick split thickness, you get more qualities of normal skin, less contraction, looks better, fair sensation, but lower graft survival and slow healing. And full thickness is most, because in full thickness there is also a difference I will tell later on. It resembles almost normal skin. Minimal secondary contraction, resist trauma, good sensation, aesthetically also pleasing. Whereas poorest survival, donor side must be closed. Whenever you are taking skin graft, you are not caring for the host side. But here when you take a full thickness graft, the donor side must be closed at any rate. Where you give graft, extensive wound, burns, so we are concerned for the wounds. So areas of primary infection with extensive skin loss and cosmetic purpose also. The full thickness indication is in adjacent tissue has pre-malignant or malignant lesions where whenever it is taken you should give a good coverage. Specific locations where this full thickness is given, tip of the nose, the helix of the rim, forehead, eyelids, concha, all those things. This is more interested for the plastic surgeon people. I think I have given a diagram, you can see that the thin, medium and thick everything, and when you take full thickness, it is completely everything along with the dermis. Partial thickness graft, that there is measurements and all these things, human remember. Split thickness is used in chronic ulcer, temporary coverage, correction of pigmented shoulders and burns also. Full thickness is, I contain the entire dermis, usually harvest from the skin is thin, where the upper eyelid and all those things. And full thickness skin graft, harvest sites can be closed primarily. Then comes the flaps. What is the flap? I think I have given the definition. Here, you are not detaching completely away from the blood supply. The blood supply is intact. So according to the donor side, whether it is local or distant, very near, taking the consideration from where you are taking, then you are telling it is local or distant. According to the tissue transfer, whether it is skin only, or you are taking subcutaneous tissue, or the fascia, or muscle and bone. So you can name it as fasciocutaneous, myocutaneous, or osteocutaneous, whatever may be. And according to the nature of blood supply, also you can take it skin flaps like this axial or random flap and all these things. Unlike a graft, a flap has its own blood supply. Consists of skin, subcutaneous tissue that are transferred from one part of the body to another with a vascular pedicle or attachment to the body being maintained for a nourishment. Means I think you can know the difference between the graft and the flap. Flap always maintains its vascularity till it is being detached or it is covering that area. When skin flaps is covering the recipient beds that have poor vascularization. Reconstruction means you see the graft when that is good vascularization, but here it is poor vascularization, therefore you are giving a flap. This reconstruction of full thickness of the eyelid and all those things, it is indicated. It is necessary to operate through the wound or lateral date to repair underlying structure. That is the one advantage we orthopedicians take the benefit from the plastics. And usually we take this at the referral case to the plastic. Once they give a flap, then we can get the house is made by the plastic surgeons, and that is the proverb what we tell, that the fools make the house, wise to stay in. So therefore we go and open and put our nail and everything, but the house was made by the plastic surgeons, usually the flaps. The muscle flaps may provide functional and motor unit. I am giving one example of the groin flap, that you are taking the superficial circumflex femoral and all these things along with the skin and the fascia. Then you are covering the hand and keeping it like this till 3 weeks. When they regenerate, then you can detach it. And after that you think of what you are going to do later on in that area. The pedicle flap that I give you, whether it is random or axial or island flaps also often done in the fingers. Supposing important fingers, say for example, for your precision movement, you require tripod. Tripod means thumb, index and middle.
So kindly stick to the times, sir, please.
Sir? Pardon?
Times, sir.
Oh, finished. I will be finishing soon. So for this, you require a flap because glabrous skin is not available anywhere except the palm and the foot. So far, till today, whatever the transformation has been done so far, nobody has brought the glabrous skin into us. No skin graft, no flap, nothing will cause glabrous skin. So therefore, this Supposing the ring finger is almost taken as the stepchild. So you can take a portion of the glabrous skin here from the tip of the ring along with its neurovascular bundle and can transport to the thumb, because thumb is the main important finger, means important object for the hand. And the basic function of the hand is to have a fist, means to not to let loose. So that is the basic function for which, and the sensation is much more important with the thumb. Thank you. I think I am according to your time.
Thank you very much, sir. Now I'll request Dr. Mazhar Abbas. He will give a talk on DDH. Okay. We will have a doubt clearance session later on. After this, we will have a short case presentation on CTV and no, yes.
ये होगा 1 मिनट। आगरा होगा, ये PGICL आगरा है, कोई फोल्डर ऊपर PGICL आगरा, ये हाँ ये। I'm aware that you are tired, but I'll hurriedly finish up my lecture within 20 minutes. I'll try to. And this is an important topic, as this topic is usually not discussed and taught very frequently in most of the medical colleges. The developmental dysplasia of the hip is my topic. This is a disorder of abnormal development resulting in dysplasia and possible subluxation or dislocation of the hip, secondary to capsular laxity and mechanical factors. Nowadays, it is called DDH, developmental dysplasia, not congenital dislocation of hip, which was the older terminology, because it encompasses the acetabular dysplasia, that simply there is a dysplasia only, and there may not be any dislocation or subluxation. There can be a subluxation, there can be complete dislocation. In newborn, it is usually reducible, except that when it is a teratological dislocation. In older children, it is irreducible. As the child grows, it becomes irreducible. The teratologic dislocation, usually it is dislocated in utero, and it is present and irreducible in neonatal examination. And it is presents with pseudoacetabulum because the head is lying above the normal acetabulum, and that forms an impression there. It is associated with neuromuscular conditions and genetic disorder, the commonly seen in arthrogryposis multiplex congenita, myelomeningocele, and Larsen syndrome. In the late adolescent, sometimes there can be there may not be dislocation. The hip may be mechanically stable, but it may be dysplastic, and it will later lead to early osteoarthritic changes. The incidence quite varies from place to place, but mostly it's common left hip, and in females, the dysplasia is 1:100, because dysplasia is more common than dislocation. And the dislocation is roughly 1:1,000, but in girls it is 1:600, in boys it is 1:4,000, and it is bilateral in 20% of the cases. If the physical examination is done by a pediatrician, it has been found to be 8.6 per thousand. If it is done by an orthopedic surgeon, it is found to be 11.5 per thousand. And ultrasound is oversensitive, and the incidence is 25 per thousand. But many children who are positive on ultrasound may not develop frank dislocation later on. So in one study by Gross and et al., ultrasound screening of 18,000 hip detected 1,000 abnormal hip, that is incidence of 55.1 per thousand. However, only 90 hips remained abnormal at repeat examination at 2 and 6 weeks. And none of the other hips with sonographic DDH developed true DDH during 12 months of follow-up. Therefore, the acetabulum develops normal in most of the children. The various associated factor or risk factor, you can call it is girl child, breech delivery, combination of both, family history, congenital torticollis is quite often associated, that is associated in 8% of the cases, metatarsus adductus and talipes calcaneovalgus. Mechanical factors like oligohydramnios, hormone-induced joint laxity, primary acetabular dysplasia and genetic inheritance, shallow acetabulum that is defined as a dysplasia trait. Some people have trait for that. And there are some cultures, they swaddle infants with a hip in constant extension. They tie the feet together. The diagnosis and clinical examination in newborn, that is below 6 months of old, the examination should be very careful in a very calm environment. The infant should be calm, relaxed, and pacified during examination. Only one hip should be examined at a time. The child should not be aggressive or crying, otherwise you will miss the finding. Artolani's test is usually done, in which you try to relocate the head into the sternum if it is dislocated. Barlow's test is where you dislocate the unstable hip. A palpable rather than an audible clunk is felt as the femoral head reduces into or subluxates out of the acetabulum. A child may be born with acetabular dysplasia without dislocation of the hip, and it may develop weeks or months later also. That is why we call it a DDH. This is another evidence. So this is how we perform the Ortolani's test. In children more than 6 months of old, contracture of the adductor muscles develop, and there is an asymmetric skin fold. And in general, the rate of DDH is much higher in hips with at least one abnormal clinical finding than in hips without any. The limitation of abduction and asymmetric skin fold are two most common findings. The Gagliard's sign occurs when there is a proximal dislocation, proximal migration of the head of the femur, and there is a shortening of the thigh. Parents also may describe difficulty in abducting the hip during diaper change because of limitation of abduction. So these are the figures of photographs of tight adductors and Gagliard's sign. On physical examination more than 1 year or in a walking child, there is a pelvic obliquity because of contracture developing, the lumbar lordosis. In response to hip contracture resulting from the bilateral dislocation in child of walking age, there may be Trendelenburg gait because of abductor insufficiency, toe walking because of shortening, and waddling gait in bilateral dislocation. Sonographic examination of a child is very important. That tells about the dysplasia and presence of hip dislocation. And it is useful before the femoral head ossification because it is not visualized on plain X-ray, and before 4 to 6 months of age. But it may produce spurious result if performed before 4 to 6 weeks of age because it will overdiagnose, because oversensitive. Many children will not develop, therefore you will overtreat them. It allows view of bony acetabular anatomy, femoral head, labrum, ligamentum teres, and hip capsule. You can measure the alpha angle. This is the angle created by a line along the bony acetabulum and the ilium. It normal is greater than 60 degree. Then beta angle is an angle created by the line along the labrum and the ilium, and normal is less than 55 degree. This is how you draw. This is head, this is abductor muscles, this is labrum, and this is the bony ilium. So this is alpha angle. This should be more than less than 60 degree, and this should be more than this is less than 55 degree, and this should be more than 60 degree. This is USG, same. This is head, this is labrum, this is the ilium, and this is we draw a line along this ilium, and the angle towards the labrum is beta angle, towards the ilium is alpha angle. This is dislocated. The graph has classified the findings of ultrasonic examination. Normal is alpha angle is more than 60 degree and the beta is less than 55 degree. In class 2, if the angle is alpha angle is between 43 to 60 degree and the beta angle is between 55 to 77 degree, it only simply shows that there is a delayed ossification, and the child should be observed for by further ultrasound examination, and nothing should be done. Or at the most, some people would like to treat by Pavlik harness. In class 3, the alpha angle is less than 43 degree and the beta angle is more than 77 degree. That shows lateralization of the head, and such children should be treated by Pavlik harness. And class 4, it is unmeasurable because the hip is dislocated. And again, the patient can be treated in Pavlik harness or closed reduction. This is radiology. The hip is dislocated. You know all these lines. This is Helgen-Reiner line. This is Perkin lines. And the head should lie in the inner, lower and inner quadrant. This is the acetabular index. You can draw a line along the cartilage and outer edge of the superior acetabulum and the Helgen-Reiner line. And the acetabular index normal should be less than 25 degree. If it is more, it is shows dysplasia. This is a center edge angle. You draw a vertical line from the edge of the acetabulum, and another line from the center of the head to the edge of the acetabulum. And this angle normal is greater than 25 degrees, considered normal. If it is less than 20 degree, it is dysplastic. The arthrogram is used to confirm reduction after closed reduction under anesthesia. It helps in identifying possible blocks to reduction, that is the inverted labrum, or it can show the inverted limbus, it can show the transverse acetabular ligament, it can show the iliopsoas tendon which crosses along the capsule and give rise to hourglass deformity. The pulvinar is a fibrofatty tissue that is filled in the acetabular cavity that will give rise to filling defect, and the ligamentum teres can also be visualized, a thickening of the ligamentum teres. On this side, this is a normal, and here you can see there is a filling defect here. The head is out of the acetabulum. Here one can see the hourglass-like appearance because of capsule is thin, compressed because of iliopsoas tendon. What are the problems of the management? The problems of management are that you have to establish the diagnosis and differentiate between the neonatal hip instability and acetabular dysplasia, subluxation, and complete dislocation. You should be very sure what you are dealing with. Then obtaining a reduction, and the reduction should be concentric reduction. And avoiding, during this treatment, you should avoid complications and allowing the normal growth and development of the hip. So therefore, the aim of the treatment is to obtain a concentric reduction, maintain a stable hip till the maturity, skeletal maturity, and stimulate normal growth and development of hip by obtaining a concentric reduction with redirection of the joint forces. And thus, if you are treating like this, will prevent complications, especially the blood supply that leads to avascular necrosis. The treatment plans depends on the various factors which consider before going for the treatment are age of the child, unilateral or bilateral, whether it is a unilateral involvement or bilateral involvement, what are the obstacles of that prevent reduction, whether the triradial cartilage is fused or open, because the various osteosmies will depend upon that, and the size of the femoral head in relation to the acetabulum. Again, this will dictate the type of acetabular osteotomy, pelvic osteotomy, and the magnitude and location of acetabular dysplasia. If the child is under 4 months and the hip is reducible by autolinear maneuver, this is one case scenario, one should use Pavlik harness for full time, monitor improvement of acetabular development by regular USG examination, and once the reduction and stability of the hip has been achieved, wean harness and follow up till skeletal maturity. This is one photo of, this is one example of reduction in Pavlik harness. If the hip is not reducible by autolinear maneuver, again one should can use Pavlik harness for reduction of the hip joint, because this is a dynamic splint. This is used for maintenance as well as for reduction also, and monitor at 1 to 2 weeks. If the reduction has not been achieved at 1 to 2 weeks, one should not use it further and do some other treatment. If it is reduced, all right, we can follow up like previous one. If there is an unsatisfactory response to Pavlik harness, that is, there is a persistent instability, there is a poor acetabular development, or there is a failure to achieve reduction, examine the patient under anesthesia, and close reduction and hip spica application is the choice of the treatment in such cases. Inability to obtain and maintain reduction, which compounds the pathology by development of posterior acetabular insufficiency, instability. It could be one of the pitfalls of the Pavlik harness. Then the femoral nerve palsy is another pitfall of the Pavlik harness. And the inferior or acetabular obturator dislocation is another pitfall, and avascular necrosis. These are the common complications of use of Pavlik harness. In children between the age of 4 and 18 months, if the hip is reducible under anesthesia and stable in neutral position without internal or external rotation, confirm concentric reduction with arthrogram and apply hip spica. Reconfirm concentric reduction in cast with CT or MRI later on, and sequential cast change at 6 weeks interval till the hip becomes stable, and follow up till skeletal maturity. This is one example of CT scan reduction. Then the hip is reducible when examined under anesthesia, but adductors are tight. This is another situation, adductor tenotomy and hip spica application. Hip is reducible when examined under anesthesia, but very unstable. That is the narrow safe zone. The degree of abduction and internal rotation that requires for hip to be stable is quite narrow. The second situation is hip is stable only in extreme abduction or internal rotation. And the third situation is it is a non-concentric reduction on arthrogram. The choice of the treatment is open reduction and hip spica application for 6 to 12 weeks and follow up till skeletal maturity. The arc of the safe zone is assessed with the hip in neutral rotation, internal rotation, and external rotation to determine the most stable position of the reduction. Hip are held in at least 90 degree of flexion, approximately 45 degree of abduction, and as near neutral rotation as possible. And CT scan should be done, or MRI should be done for confirmation of diagnosis in the spica cast. So this is what the safe zone. If it is wide, it means the hip is stable. If it is narrow, it means the hip is very unstable. Children, hip is not reducible by closed means under anesthesia. Then the choice of treatment is open reduction and hip spica application. In child less than 1 year of age, open reduction can be performed by either medial or anterior approach. In child older than 1 year, the anterior approach is preferred, because if there is an inverted limbus, medial pulvinar, or large ligamentum teres, then the medial approach, one cannot reach these pathology through the medial approach. So this is a photographic depiction. This is the incision. These are the structures. I'll not go into the details of the open reduction because the time is short. Indications for femoral osteotomy. What are the indications for femoral osteotomy? Reduction is stable only in internal rotation. If the reduction is stable only in internal rotation, obviously the choice is derotation osteotomy. That corrects the associated femoral anteversion and reducing the need for extreme internal rotation, and thus reduces the incidence of avascular necrosis. So this is the advantage of derotation osteotomy. If the reduction is stable in abduction, varus osteotomy, and reduction is stable in abduction and internal rotation, then you can combine both varus and derotation osteotomy. And if it is a difficult reduction, or tight reduction, femoral shortening is indicated. Indications for acetabular osteotomy. Patients between the age of 18 months to 6 years. If the patient is between this age, what are the osteotomy that you can perform? There is a radiological evidence of acetabular dysplasia. There is a concentric reduction and normal size acetabulum. These three situations. Salter's osteotomy. The second situation is concentric reduction but large acetabulum. Then Pemberton or Dega osteotomy that reduces the volume of the acetabulum. Between 6 years to skeletal maturity, acetabular dysplasia, concentric reduction and normal acetabulum size. Salter or steel or Tony's osteotomy. Steel osteotomy is a triple osteotomy because in bigger children we go for steel osteotomy. The children, smaller children you go for, younger children you go for the Salter osteotomy. Concentric reduction is not possible or not or a small acetabulum. Here you want to increase the size of the acetabulum, or you want to give a shelf to cover the head of the, if the head is not reduced, you want to cover the head with the acetabulum. The shelf procedures or Chiari osteotomy is done for such situation.
0 to 6.
At skeletal maturity, the concentric reduction is achieved. Then you go for a steel or Tony's, that is a triple osteotomy. Concentric reduction not possible or a small acetabulum, you go for Chiari osteotomy at skeletal maturity. Correction of vestibular dysplasia. The vestibular dysplasia may be abnormally oriented, although of adequate capacity. The vestibulum may be too large so that the femoral head can ride laterally and become uncovered. These are the various situations. The vestibulum may be too small relative to the size of the femoral head. So this is how here. This is the normal. Relationship of the acetabulum and the head. Here, this is normal. Here, the acetabulum size is large and the head is small. Here, the acetabulum size is small, but the head is large. So, depending upon these three situations, here we do the Salter osteotomy. Here we do the Dega or Pemberton osteotomy. Here we do the Chiari osteotomy or the augmentation osteotomy. The redirectional osteotomy, that is cartilage is fused. These are the various examples. This is this. The Salter osteotomy, this is the double osteotomy. This is through the conjoint ramus, not one of the superior or inferior ramus, the conjoint ramus. And this is the triple osteotomy, example of the triple osteotomy. Then the augmentation, that is the volume increasing osteotomy, that is the Estalis osteotomy or the Japanese tectoplasty is done, where the size of the acetabulum is small or the head is not reduced into the acetabulum. You go for these procedures. This is Estalis procedure, this is Japanese tectoplasty. This is another photograph of Estalis augmentation osteotomy. This is an example of Chiari osteotomy where you displace and thus there is a covering of this part of the supraacetabular area over the head of the femur. Volume reducing osteotomy, that is the Pemberton osteotomy or the Dega osteotomy, where the size of the acetabulum is large and the size of the head is less. In those situations, we go for, and the Dega's osteotomy is, this is the Pemberton osteotomy. We start from the supraacetabular area, and the line of the osteotomy is up to the triradiate cartilage. Just before that, we end before that. And in Dega's osteotomy, we do not go towards the cartilage, but towards the inner ileum. But both are incomplete osteotomies. Both are incomplete osteotomy. These are one example of Dega's osteotomy. This is one example of Pemberton osteotomy. You want to ask? Because of tilting. Once you put in the graft, after cutting up to this, if you put in graft, you tilt this portion downward, the volume will be decreased. Because it hinges on the cartilage here and here. There is a tilting like this. Then the treatment in children between the age of 18 months to 8 years, it is just a repetition of the same slide, age 8 years and mid-adolescent. Thank you very much. I have gone because of shortage of time. I went.
Thank you, sir.
I would like to ask, if you want to, a question, I'll like to answer those questions. Because I went a little hurriedly because of shortage of time.
You all are welcome to raise your queries regarding this lecture and any of the previous lectures. If you want to ask any questions, you are welcome.
You can come in front.
You can come in front.
You can come in
Yes.
front and have your queries.
Have your queries. You can ask the questions. Can you give the mic? Mic dena sir, please.
Mic to sir, please.
Mic dena.
After reduction, if there is still an abductor insufficiency, you can go for that. Bilateral, yes. If there is a bilateral dislocation, the other signs will also be positive. There will be tight adductors, there will be limitation of abduction movement, there will be asymmetric folds. And obviously, if it is reducible or unreducible, that can be detected. Or you can do the telescopic test also. Telescopy will also be positive. Any other question?
You can ask the questions regarding previous lectures, regarding polytrauma. Professor Alok is there, Professor M. Ray is there, Professor Sahu is there. You are welcome to ask questions. You can clear your doubts. No, actually, no, they had gone. She has gone. Everybody's tired. Okay, no questions. So here we. Tomorrow we'll have a very interesting session on CTV and cerebral on Perthes. We'll start at sharp 9 tomorrow. Today we start 1 hour late. Tubercular arthritis office, CTV, Perthes, and about OT discipline. So you are all requested to come at time, and we will start the session at sharp 9 a.m. in the morning. Thank you everybody. Thank you.